Okay, we're going to get into mood and anxiety, neurology, neurochemistry, and neuroendocrine-immunology. This is going to be really critical to understand what's happening with mood disorders. So the academic goal is to review the neurophysiology mechanism of the limbic system. And then the clinical goal is to understand how these underlying clinical mechanisms can be caused from these dysfunctions in these systems. Okay, so neurophysiology of the limbic system. So here's what I want to do. I'm going to go into like the depth of the limbic system. So what we're going to do is we're going to start with limbic regions, and then go to circuits, and then go to cells, and then go to cellular functions, and then go into mood disorder. So what I want you to understand is whether it's anxiety or bipolar activity or depression, whether it's major or minor depression, ultimately what you have is you have something dysfunctional along the regions, the circuits for all the different parts of the limbic system that work together, the cells in these different regions, or the cellular functions of self in these different regions that are not working. So limbic regions include the prefrontal cortex, the amygdala, cingulate gyrus. There's more. We'll go through them in detail, but each of the main ones. And then these limbic regions connect to each other. And then these are circuits. And then there's general mood circuits, depression circuits, anxiety circuits, bipolar circuits. We'll go over some of those. And then these regions of the brain and these circuits work together. And then within the circuits of the brain, then you have the cells in these limbic regions, the cells within these circuits. These are neurons, microglia, astrocytes, vascular endothelial cells. And then these cells are part of the limbic circuits, and these circuits are part of the regions, and they're all functioning together as a system. And then the cells in the limbic system then have their cellular functions, and that's where the neurochemical synapse comes in, neuroimmune activity comes in, the blood barrier impermeability, cerebral circulation, neuroplasticity all come in. These are the normal functions that take place in the limbic regions, and these cellular functions impact cells, and these cells impact circuits, and these circuits impact regions, and we have this normal system here. And again, any dysfunction in any part of this system leads to a mood disorder, right? So we can't just say, our nutritional protocol for depression is this, because maybe for some people that have depression, they have some significant neuroinflammatory microglia, blood-brain barrier permeability issues. And if for another person who has depression, maybe they have some neuroplasticity, neurodegenerative types of mechanisms. If another person that has major depressive disorder, maybe they have vascular endothelial dysfunction, cerebral circulation issues impacting these circuits that are causing depression. So this is where you can't have a protocol for a mood disorder based on the type of mood disorder. You have to realize that the mood disorder is just a reflection of some of the circuits in the limbic system being off. And certain anatomical pathways and certain circuits that are dysfunctional are going to lead to anxiety, certain dysfunctional symptoms are going to lead to depression, and so on. So what I want to do is go into the limbic regions first, the areas of the brain. Now we talked a little bit about this, but the limbic system is really the emotional brain, right? So when you look at the limbic system here, you can see these areas that are in different colors here. You can see the cingulum, you can see the fornix, you can see the hippocampus, pineal gland, the amygdala, areas of the frontal cortex. These are all involved with the limbic system. They're in the very center midline area of the brain. So the limbic system is involved with regulating many motivational behaviors, such as obtaining food, drink, and sex, organizing emotional behaviors such as fear, anger, aggression, and with storing memories. Right? So this is the emotion you have, the motivation, drive you have. These are all limbic system functions. Now within the limbic system, let's go into the different regions. So the prefrontal cortex associated with the emotional regulation. And the prefrontal cortex includes the dorsolateral orbital frontal, meaning these front areas of the brain. And like I was showing you some illustrations earlier, but when this area of the brain is dampened in activity done with imaging studies, you have depression. So the prefrontal area is very involved with depression. And this is the area that also is involved with critical thinking, executive functions, problem solving, and planning. So when the prefrontal cortex is involved, people have a hard time doing anything, wanting to do anything. They can't plan, they can't solve problems, they can't think, and they're just in a non-functional state, okay? Then the cingulate gyrus, this area here, kind of like the C shape here, the cingulum right over here, regulates regulation of autonomics, emotions and autonomic modulation. So information from the cingulate area goes right into the hypothalamus area, and these hypothalamic pathways then activate the pituitary, and that helps regulate the endocrine functions that are involved with emotions. So regulation of emotions, autonomic functions, endocrine functions, these are all involved with the cingulate. And then when people have injury and damage to their cingulate, they can get, it results in inappropriate emotions. So they can see acts of violence and start laughing. They can see things that are really happy and then start crying. It's just things that just are inappropriate in a sense. That's where the cingulum injuries express as. The hypothalamus modulates the neuroendocrine immune response. This is, what activates the pituitary. You get all the different pituitary releasing hormones to deal with the emotions impacting the endocrine system. And then the amygdala we talked about earlier. This leads to activation of anxiety. Damage leads to loss of fear and aggression. So this keeps us in check to survive. So we have some fear to not do certain behaviors and certain tasks. And the amygdala plays a central role in anxiety fear response and activates the sympathetic centers. So there's a direct connections between the amygdala and two autonomic centers in the brainstem, which we'll go over, that activate the sympathetic response. There's some activation of the sympathetic response to the amygdala, to the ACTH pathway, the pituitary to drive cortisol, but there's also direct projections from the amygdala to autonomic brain centers to activate the system, spinal cord, sympathetic chain, sympathetic response. But it's basically there as our fear survival area of our brain, and the key area that's involved with anxiety. Then we have an area within the limbic system that's involved with the basal ganglia. The basal ganglia obviously is involved with other functions too, like sensory pathway integration, motor pathway integration, and limbic root integration. So this modulates activation and inhibition of the limbic system. It kind of calms and modulates everything together. The basal ganglia direct pathways activate the prefrontal cortex. The basal ganglia indirect pathways suppress the amygdala and anxiety fear centers. So people that have dysfunction in their indirect pathways, they may not be able to calm down their anxiety. There's this, for some people, their sympathetic pathways are being activated, their amygdala is going crazy, but people that have basal ganglia injuries or dysfunctions, they can't suppress that activity. And then the basal ganglia direct pathway activates the prefrontal cortex that can help with changing patterns like depression. So it's kind of like the modulator, excites, inhibits, keeps the tone of the limbic system. And then the hippocampus is the area that's involved with memory of episodic emotional events. So memory formation can activate this amygdala pathway. Things like PTSD are strongly linked with the hippocampus. Social anxiety causes activation of the hippocampus and the amygdala in imaging studies. So these are the major areas of the brain. And to put it very simply, when you just think of mood, and obviously it's not this simple, but just a place to start. Just think of depression as decreased activation of the prefrontal cortex, anxiety as increased activation of the amygdala, and bipolar as immune activation of dysfunction in the limbic circuits, limbic regions. That's the base, the good place to start, okay? So we talked about the different regions of the brain. Now these regions of the brain could be abnormal or not functioning well due to it not actually developing all the way, like in a neurodevelopmental delay, or from atrophy of the brain from neurodegeneration. So let's go into why some of the actual regions of the brain may not be functioning well. So one of them is they're just not developed all the way. And there's a window of development that if children get past, then they become adults with these developmental disorders, as we see with things like ADD and autism, for example. So in the limbic regions of the brain, if there's neurodevelopmental delay, obviously from the clinical history, there's a history of missed milestones, there's a history of patterns associated with ADD or OCD or autism spectrum disorder or motor sensory tics or Tourette's syndrome or sensory integration disorders or specific learning difficulties. So you pretty much know from their history that they've had these issues when they were children, unless you're dealing with a child that's having mood disorders. But it's, first of all, if they're a child that has mood disorders, you would and they have developmental delays, you would expect it, because the areas of the brain that are involved with neurodevelopment have a strong connection to these limbic regions and their function and connection as well. So in those cases, ultimately, what you're trying to do is improve the health of the brain. A lot of the applications we talked about in the Neurology Institute, childhood developmental disorder course, we don't have time to get into all those. The key point is that children with developmental related conditions like OCD, ADD, ASD, Tourette's, tics are going to have mood disorders because these regions are involved. And the limbic system in children is developing, and if you look at some of these studies that are done when they look at densities, there's reduced density and volume of frontal lobe tracts in ADHD. So you can see controls compared to ADHD subjects. So these circuits involved with these regions are much less. This compared to this. And then a control, you see all these branches, all these different colors. It's less here, and so forth. So we know that there's differences in the volume of these densities of these pathways involved with childhood developmental disorders. And here you can see nerve trap fibers that are involved with social interaction, eye contact, feeling rewarded with autism, and typical children. So here you can see these nerve fiber tracks in normal, or a typical child, I should say, and then a child with autism. You can see that they're much less. So there's lack of development in these different regions of the brain. Now remember, when you look at neurodevelopment, there's windows of opportunities. The first critical window of opportunity for getting out of a neurodevelopmental stage, the problem or having proper development, is that first 1 to 2 year window. That's when the brain is really still having some neuron migration, a high degree of white matter, gray matter development. And then by age 10, the gray matter development is pretty complete. And by age 20, their neurodevelopment is typically done. The white matter is fully developed. Here you can see a study that illustrates these when they look at imaging studies. So here you can see gray matter is red, white matter is listed as pink, cortical thickness is green, and the surface area. And you can see from 20 weeks to the first years, and right about 2 years, boom, there's a lack of development, normal development. So the potential for someone to grow out of a neurodevelopmental disorder is much greater the first 2 years if they have all the proper variables. For example, breastfeeding has a huge impact on this. And then the brain's still developing. And then by 10, if you look at gray matter kind of stops, starts to go down. So that gray matter development window is off. When we look at neurons, the neuron itself and the cell structure, the nucleus is the gray matter, and then the myelin sheath is the white matter. And then by age 20, you see white matter just kind of tip off. That's its peak, and then it's done. So when you look at these critical windows of time, if you have a person that's a child with a learning developmental disorder, and they go past these windows of time, opportunities, and don't really resolve their brain connectivity and their brain health, then they become adults with mood disorder susceptibilities. And then in those cases, you're trying to figure out how to improve their cognitive emotional resilience. Things like sleep, things like blood sugar control, things like exercise can help with them. But these pathways are hardwired, and of course there's some potential for plasticity, but they're just completely different at that point of the game. So one of the things that can make a person very susceptible to mood disorders is the developmental delays that were never optimized before they hit those windows of time where their brain can develop. So always be aware of that. So you're going to expect your ADD, OCD, ASD adults to always be susceptible to mood disorders. And the clinical application you see with them is to try to improve their resiliency, things that can make these circuits dysfunctional much easier. So if you take a childhood developmental disorder adult, that's an adult with ADHD, and you cut out their sleep, you cut out movement and exercise and activity and social interactions, everything's going to get much, much worse. So what your clinical strategy is to know is that these circuits are involved because of developmental delays, and then improve the resiliency and reduce these factors when it comes to managing the mood disorder. You're not going to do a nutraceutical protocol for anxiety for them or depression for them. You're going to have to try to improve the resiliency with the pathways they have. Now, another thing that can impact limbic regions themselves, besides developmental delays that lead to lack of full development and growth, is just the atrophy, the opposite. So instead of developing, it's just starting to atrophy. So brain atrophy can be from certain genetic diseases, neurodegenerative disorders being the most common one. Alcohol abuse can definitely degenerate the brain. It's more overlooked. And when you look at studies of brain function and Alzheimer's disease and frontal temporal dementia, their limbic circuits are degenerating. So their ability to be efficient in managing their mood, motivation, drive, sense of pleasure, pathways that dampen anxiety, pathways that activate the dampening of the fear pathways, they can all be dysfunctional, and you can have some of these mood disorder pathways involved. And for them, your goal clinically may just be to slow down the neurodegenerative process, optimize the brain health. And we went into those in great depth in the Crosby Institute Cognitive Decline Dementia course. So we don't have time to get into them more, but you should expect some of these early symptoms of neurodegenerative diseases, especially dementias, to express as mood disorders, both depression and anxiety. And when you look at, degenerative change, when you look at mood disorders, and people, when they look at studies and imaging studies of brain disorders, one of the things that they see with major depressive mood disorders is that there's atrophy. There's less volume in the frontal cortex, less volume in the cingulate cortex, there's less volume in the hippocampus, and even in the amygdala. So these pathways are just starting to atrophy, and this is where mood disorders are coming out. And if you don't address their brain health and slowing down the neurodegenerative process and trying to improve neuroplasticity and neuroconnectivity and try to improve their mitochondrial efficiency, they can definitely go downhill really, really quick. It's actually, they go down in a fast forward accelerated pathway. So as soon as you see a mood disorder and you see signs of cognitive decline or any signs of neurodegenerative disease, you want to jump on that as soon as possible. And as you improve the risk factors for neurodegenerative disease like dementia and cognitive decline, you can typically see a change in their mood and their anxiety as you go through those pathways because they overlap. And then also research has shown that in addition to volume size and glial density of the regions of the brain with neurodegenerative diseases that impact mood, there is decreased like mitochondria within the neurons themselves in degenerative diseases. So less ability to make neurotransmitters and release neurotransmitters, and less ability to have proper dendrite branching, axonal branching that take place. So those are issues. So clinical pearl, when we look at regions of the limbic system, you should always suspect neurodegenerative disease with any older patient with a history of major depressive disorder or chronic generalized anxiety disorder. Then I made a chart for you to go over the key things you should definitely look at as a clinician. So anytime you see chronic depression or anxiety, so let's say more than 6 months, definitely more than a year, more than 2 years, the patient's older than 45 years old, you should immediately see if they have any cognitive impairments or any slowness in movement. The cognitive impairments, the best way you can assess that is use the Montreal Cognitive Assessment Form. And if the levels are less than 25, then you have mild cognitive impairment, right? So less than 25, they can maintain activities of daily living with their cognitive functions down, that's mild cognitive impairment. If they're unable to maintain activities of daily living, like they need to be driven to the doctor's appointments, that they can't find directions anywhere, they need help, they need help with their bills, they're starting to lose activities of daily living, then they're heading into the dementia, Alzheimer's pathway. If they have stepwise, localized deficits, like all of a sudden they get a little bit of slurred speech and then it comes back to normal, then all of a sudden they get a little bit of dizziness and then it comes back to normal, those are signs of vascular dementia. And if you see personality changes where all of a sudden they're cussing at people, going to a restaurant, they're always very polite, or they're yelling at people, or they just completely like different music, or all of a sudden become a chain smoker for no reason, or start gambling, that's when you start to think about frontotemporal dementia. And then if you have someone with chronic depression and anxiety, you should always look at their muscles, and if they have cognitive impairment and rigidity and slowness, you think of Lewy body disease, Lewy body dementia. And if they just start to have only rigidity and lasso arm swing, get constipation, and just feel stiff and they're not moving very well, you got to consider Parkinson's disease. So just remember, the earliest clinical symptom for both Parkinson's disease and different forms of dementia is chronic depression and anxiety. So, your patient that's chronic anxiety depression may be really showing you that let me say it differently. Your patient has chronic depression and anxiety may be expressing their earliest signs of their neurodegenerative disease with those symptoms. So you want to jump on top of that as soon as you can, okay? Now, those are all involved with limbic regions. So the regions of the brain themselves can atrophy or they cannot develop properly. Now, we can also have mood disorders caused by the limbic circuits themselves not functioning well. So when we talk about limbic circuits, what we mean is there's different regions of the brain involved with the limbic system. So the amygdala, the hippocampus, the areas in the frontal cortex, they're all connecting to each other. So there's pathway connections to each other, right? So those are called circuits. And you could spend a lot of time reading about these circuits if that's your interest. Our goal in this course is just to talk about how these circuits can be injured or dysfunction and lead to mood disorders. Now, when we talk about circuits, and we know when we look at mood disorders and we simplify mood disorders as depression being decreased activation of the prefrontal cortex, people can get depression not only from the frontal cortex atrophying or not developing properly, but if the circuits to the frontal lobe are dysfunctional. So if the pathways from other areas of the limbic region to the frontal cortex are not working, we can get depression, okay? And here's a statement I put on the slide. If you're having an emotional response from stimuli and thinking, the prefrontal cortex and limbic system are involved. So if you listen to music and start analyzing the music and the sound and start thinking about if you like it or don't like it or memory, you're activating the limbic system. So anytime you're having an emotion, you're having the limbic system, the frontal cortex. Your conscious awareness, attention to it is your frontal cortex, okay? And then any pathways neurochemically like dopaminergic, glutamatergic, GABAergic, serotonergic, catecholinergic pathways that activate the frontal lobe can also be involved and lead to depression. So any pathway that goes into the frontal lobe, I listed some of these in the arrows here, if they're dysfunctional, you can have these limbic circuits involved with depression involved. And these limbic circuits are going to come in through activation of social interpretation relationship pathways. When you see someone, their facial response to you, their voice, their pitch of tone, their visual interpretation of seeing art, cognitive tasks, food you taste and enjoy and decide it's pleasurable or not pleasurable for you, exercise and movement, music that you start to appreciate whether you like it or not like it. Those are going to all activate that frontal cortex. And if you want to cause depression, just take these things all away. No social relationships, no cognitive tasks, food that has no flavor, no movement, and no sound. And you're going to cause massive depression with anyone very, very quickly. Or put them in a pandemic and have them not contact anyone and then see all the depression come out, which is something we'll talk about. But it happens from lack of activation of these circuits into the frontal cortex. And studies have shown this. This is a study that was published. I'll just read the title to you. Differential effect of environmental enrichment and social isolation on depressive-like behavior, spontaneous activity in serotonin, norepinephrine concentrations, prefrontal cortex, and ventral striatum. Basically what they found was lack of stimulation, social enrichment. Serotonin, norepinephrine concentrations in the brain just went down to nothing. They just shut down. There's no activation of the frontal cortex. So activation, stimulation is really critical. And then here's another paper that was published that goes into some of these same concepts. Different susceptibility of prefrontal cortex and hippocampus to oxidative stress following chronic social isolation and stress. And they actually found that social isolation causes oxidative stress and inflammation injury to the brain. And other studies have found the same thing. Growing neuroscientific research emphasizes that social interaction and environmental stimulation are of vital importance for physiological brain function. It is further highlighted with socio-environmental deprivation. It can have damaging effects on the brain, many of which entail irreversible consequences. So major issue we have had recently is high rates of suicide in children and adults. But in children, it's off the charts. And the pandemic has triggered these changes in a timeline fashion. And there's some kids that were definitely deprived of physical exercise, social interaction, cognitive tasks, visual stimulation, auditory tasks in the depth of, in the deep, isolation periods of the pandemic. And this changes their activation of these circuits to the frontal lobe, and they get severe depression, right? But what they found is some of these kids, once all these restrictions were lifted, have never come out of it. And they're still suicidal, and they still have depression, and they still need management. And part of the interesting thing is that when the brain itself, these limbic circuits are not activated, there is inflammation, oxidative stress, and damage to those areas of the brain. Now in animal models, when they try to cause depression, you know what they do? They decrease all input to them. They put them in a cage, they can't move, there's no sound, there's no smell, they decrease all inputs. Then they realize their brain is no longer firing and they have depression-like activity and movement behavior, and that's when they'll use different chemicals and drugs to test depression molecules in animals, right? So that's how you create depression. So you decrease all these different inputs, okay? At the same time, if someone has movements, exercise, social interaction, cognitive challenges, visual stimulation, auditory stimulation, they can get a good mood, motivation, concentration, and passion, right? So it's one of those things that's really critical. And for people that are in a state of depression, like they don't want to go and move and exercise and social interact and take on cognitive tasks or challenges. They don't want to do anything. But once they can and get into it, a lot of times that's the way out of the depression pathways. So that's one of the things too, is like you see these kids that have depression or learning disorders, and their kid doesn't want to learn, doesn't want to develop, doesn't want to do any of these things, they fight and yell, and the mom and dad or parents are not stepping up and causing some situations which are a little challenging for their child. They never get out of it. Now it doesn't have to be a child, it could be a spouse member, it could be a loved one, that they just get stuck in these depressive pathways and they don't get put in these situations to activate the brain. The brain circuits have to get activated to change mood, depression, and get that frontal lobe working. So this is one of the key things with decreased depression. And when you do your history and do your workup, you got to see, are they in a, environmental stimulation, are they in an environment with lots of environmental stimulation? Are they getting enriched with lots of different types of inputs? And if they're not, that could be a reason why they're depressed. One of the biggest ones is movement. If you don't move, you get depression. So movement is one of the huge ones. And if you don't interact socially, you get depression too. These two are really, really critical. Okay. Now, if we look at the simplification of mood disorders and slip over into anxiety, this amygdala pathway. This amygdala pathway is really the central role in anxiety and fear, which we want. We want to be protected from doing things we know from a memory standpoint can hurt us, harm us. We have fear of them, things that can kill us, damage us, and so forth. But we also want it to be dampened and modulated, and we should be able to control those pathways, right? People that get their amygdalas damaged have no fear. They'll do whatever, okay? So it's really our brain circuitry for anxiety, and I showed you these images before where you see during states of threat and detection, the amygdala lights up, the prefrontal cortex lights up because you have to have executive function, cingulate fires up. That's for you to have your emotional response and get your heart rate up and your autonomics working. Amygdala fires into the cingulate, into the hypothalamic pathways, so you have your stress response. The amygdala fires into the autonomic pathways in the mesencephalon midbrain area to activate those autonomic pathways, which activates the sympathetic chain. Insular cortex is involved with emotional perception, emotional environment recognition, interoception, hippocampus memory. So they're all kicking in with an anxiety response. And you can see here insular and amygdala activation with anxiety response. Like with PTSD, you can see that their amygdala is activated, but there's a lot of blue is hypoactivation and red is hyperactivation. So blue, their frontal cortex, the reasoning to calm down, nothing's bad here, shuts down, and their amygdala is activated. So if you were in a situation where you think is dangerous, like you hear a sound that sounds like a gun firing, you can go, hey, that wasn't a gun firing, that was just a tire, everything's fine, I'm in the city, I'm not in battle. But in PTSD, their frontal cortex reasoning pathways shut down, and their amygdala pathways are activated. Social anxiety, their memory, their hippocampus areas really light up with their amygdala. Same with social phobias. So when they look at imaging and scan studies, they can see certain areas shut down, and certain areas activate. With PTSD, the planning, executive function pathways shut down, the amygdala pathways activate. Social anxiety, hippocampus, amygdala really activate. Social phobia, amygdala cingulum, is involved with emotional arousal and appropriate responses start to activate. And then when they look at these imaging studies, looking at which areas get activated and what areas get suppressed, you can see, like for example, with post-traumatic stress disorder, You can see severe areas of hypoactivation in the frontal regions, reasoning and planning, and severe activation in the stress response pathways. Social anxiety disorder, the whole insula amygdala just going crazy. The frontal cortex is not even involved. And ultimately, these stress responses in the limbic system activate the endocrine stress response. ACTH gets released, adrenal glands get activated, catecholamines get released. And then we have these different catecholamine surges that increase our heart rate, dilate our pupils, and allow us to deal with the stressor. Here you can see an illustration of the midbrain. The midbrain is the autonomic center, unrelated to hypothalamus. The hypothalamus pathways control the endocrine cortisol pathway, but the pathways from the amygdala to the midbrain and brainstem activate the sympathetic epinephrine norepinephrine response. So here you can see something driving the midbrain activation system. It could be drops in blood sugar, it could be inflammation, it could be a psychological threat. The intermediate lateral cell column gets activated. It activates the sympathetic chain, adrenal activity gets promoted, epinephrine, norepinephrine come out, and then you get increased sympathetic responses, heart rate, anxiety, irritability to sound and light. Those things all start to happen. Now, when you look at these circuits, these limbic circuits, with what happens in anxiety circuits, one of the things that can happen is that the amygdala itself is sensitized. So what does that mean? That means there's plasticity of stress response projections, there's sensitivity of catecholamine receptors, or there's post-synaptic applications of catecholamines. Like this can happen with PTSD, this can happen with acute stress disorder for a period of time. But in order for you to feel anxiety, that amygdala has to get activated, right? So if catecholamines are stress hormones, and those stress hormones can be triggered by the amygdala being activated, but those stress hormones then come in and turn on the amygdala. So for whatever reason your catecholamines were activated, you can have your amygdala get very, very active and you can experience a lot of fear. So there are some people that have sensitized catecholamine receptors. Now, there's some people that genetically have sensitized catecholamine receptors in their amygdala. And there's some people who develop them from various triggers in their life, especially early on in their life. And then once there's a receptor site response in the amygdala, the response can be amplified. And these amplification responses also happen with sensitization to the amygdala. So one of the things that happens if people have anxiety issues, they get a sensitized amygdala. So they're very, very sensitive for catecholamine levels. Now you could have someone who's got a sensitized amygdala, has chronic anxiety, and you can't desensitize the amygdala itself, but you find out that their catecholamine levels are also going up because they miss meals all day. And as their blood sugar levels drop, catecholamines have to be released to break down glycogen and get their glucose levels back up. And that is driving their sensitized amygdala pathway, or increased sound and light, or really activating their catecholamine receptor pathways, because the pupils have to dilate to the stressors, and that's too much for their system. So you can kind of remove those situations. But sensitized amygdala is one reason why people have these anxiety circuits activated. Another reason, complete independent of that, is an activated vestibular system. So when there's sensations of movement and falling from the vestibular disorder or cerebellar injury degeneration, that can activate the amygdala pathways. So when you look at the neurology of this, you have different receptors in your inner ear, your vestibular apparatus, and these vestibular apparatus, these semicircular canals, these otoliths, they get input from your head moving in motion, and they fire directly into the cerebellum. Your cerebellum has to integrate those inputs and figure out how to suppress them. And then some of that input goes into the midbrain regions itself. And then these can then activate the stress response. If you really want to know the details of that in great detail, check out this paper called Vestibulosympathetic Responses. It just goes into how activation of the vestibular system activates the rostroventrolateral mesencephalon, amygdala cell column, parabrachial nucleus, nucleus tractatoris, and can activate these centers. But the simple concept is if you feel like you're falling, your body has to increase its catecholamines and activate your fear center so you protect yourself. So people that have benign positional vertigo and they feel like they're falling, people that have cerebellar degeneration, cerebellar disease, can't gate input coming in from gravity very well from their inner inputs, and they activate these midbrain centers. So here's an illustration. So cerebellar injury, cerebellar degeneration commonly occurs with alcohol abuse, cerebellar autoimmunity with gluten sensitivity, GAD autoimmunity for gluten sensitivity, celiac disease, like GAD65 receptor antibodies that reduces GABA activity. I should say GAD65 enzyme autoantibodies. They can impact GABA production. And then a person has sensations of vertigo, motion-induced nausea, poor muscle stability. These pathways activate the midbrain sympathetic centers. You have your heart rate go up, catecholamines go up, and you get symptoms of anxiety. So you'll see many people have cerebellar ataxia, gluten ataxia, have these anxiety pathways driven because of that. But no one checks. They just assume they have anxiety disorder. One of the easiest things you can do is just have them close their eyes. We'll talk about this in physical exam. Anytime you have a patient with anxiety, close your eyes, shake their head. Stop. Do you feel like you're moving? The answer should always be no. Do you feel any dizziness? The answer should always be no. Do you feel anxiety? The answer should be no. If they shake their head like this for like 10 seconds and they stop and they feel anxiety and they feel dizziness and they feel vertigo, then you know that their anxiety disorder is usually due to cerebellar dysfunction disease. Then you look at your celiac disease, your gluten ataxias, your cerebral autoimmunities, and within like the first 10 seconds of working up a person who's had chronic anxiety for 20 years, you figure out what's happening with them, and then you figure out how to treat them. Okay, so knowing these pathways are really, really critical. And the pathways in the midbrain that are activated with these inputs of the vestibular system also activate the superior colliculus and inferior colliculus in the midbrain. Inferior colliculus where sudden sounds come in, and superior colliculus is where visual inputs come in. This is why when it's a neurological based anxiety pattern, especially coming from the vestibular system, these patients are extremely sensitive to loud sounds. Like loud sounds, if you clap like next to them, they can get their heart rate go up. As a matter of fact, you can put a pulse ox on their fingertip, we'll talk about this in the physical exam, and just clap next to them, and then they will have the heart rate jump. Or for the visual pathways, you can basically put them on a heart rate monitor, and you can turn the lights on in your office off like this, and then you'll see the heart rate go up like crazy. So those are neurological based anxiety disorders. Okay, and most of those pathways that are activated from these areas are from these vestibular dysfunctions. Okay, and if you check their balance and see that they don't have good motion and sensation and history of dizziness, their chronic anxiety disorder may really just be a vestibular issue. Now, another part of these anxiety circuits that can be involved is these basic ganglia pathways. So impaired basic ganglia suppression of the amygdala is another anxiety circuit that can cause chronic symptoms of fear and anxiety. Injured projections of the basic ganglia indirect pathway that suppress the amygdala GABA production. So let me show you what I'm talking about. So when you look at the brain, here's a coronal slice of the brain. You can see the basic ganglia. The basic ganglia has direct and indirect pathways. The indirect pathways suppress the thalamus and these amygdala pathways to calm everything down, the amygdala to calm everything down. And the basal ganglia activates and inhibits, or put it differently, modulates, because it does both, motor circuits, associative circuits with like sensory, auditory, cognitive thoughts, and then limbic circuits, which is emotionals, mainly the amygdala pathway. Like for these motor circuits, let me give you an example. If you just when you move your arm, and let's say you want to touch your nose, if your frontal cortex is activated, your motor strip is activated to touch your nose, without the basic ganglia, you'll just do this. The basic ganglia will calm everything down so you can do it. Or if the basic ganglia is injured, your arm is always moving. It's called hyperkinetic disorder. So the same thing translates to the amygdala. The basic ganglia indirect pathway is injured. You can have pathways to the amygdala that can't be suppressed. So it's like a hyperkinetic muscle movement disorder where someone's always moving, or like tics. Tics are hyperkinetic movement disorders. Their amygdala pathway is always activated and firing. So injury to these basic ganglionic loops involving the limbic system can be a major cause for anxiety. So here's an illustration of these circuits. Basic ganglion direct pathway, inhibition of the amygdala, and that will calm down the fear and anxiety at any time and modulate and gate it so it's not unproportional. If there's, here you can see the basic ganglia, the motor loop, which we talked about. If it's not working well, you get hyperkinetic movements like like tics and motor disorders. And if the limbic system is not dampened, then you get anxiety, rage, anger, violence, compulsiveness, and so forth. So when there's injury to the basic ganglia, inability to suppress the circuits, there's limbic loops involved and you get anxiety. So those are the key things there. Okay, now, in addition to the basic ganglia pathways, or similar pathways that sensitize the amygdala of these circuits that cause anxiety, we have impaired frontal cortex activation of the basic ganglia. So we talked about the basic ganglia suppressing the amygdala, but the basic ganglia gets most of its input from the frontal cortex. So when the frontal cortex can't excite the basic ganglia or activate it, that's why it's the plus sign, then the basic ganglia indirect pathway can't inhibit the amygdala. And by the way, when you see people that have mood disorders, a majority of them have both depression, which is decreased frontal cortex, and anxiety, which is increased amygdala. So when this frontal cortex projections of the basic ganglia are not working, you'll get depression and anxiety because of these circuits. So here you can see an illustration, frontal lobe executive function. Frontal lobe is injured. The frontal lobe can't activate the basic ganglia. The basic ganglia can't inhibit the limbic system. Then you get anxiety. So that's another key circuit of anxiety pathways. Now, in addition to the basic ganglia activation by the frontal cortex, impaired hippocampus amygdala circuits are also involved in especially decreased hippocampus activity or volume. And when you look at the hippocampus is right here. It's the Latin word is for seahorse. With certain anatomical slices, you can see seahorse. But these amygdala pathways, these memory centers of the campus project right into the amygdala. And they have this modulating, regulating effect there. And these hippocampus pathways are loaded with cortisol receptor sites. And high cortisol over a period of time does cause atrophy of this area of the brain more than any other area of the brain. And those with PTSD have atrophy of these areas of the brain. So when they look at imaging studies to see what's happening with PTSD brains, they find one common thing. Those with reduced typical activity show more severe PTSD symptoms. And not only did they find that the hippocampus is atrophied in PTSD patients, but the volume, the more atrophy they have, the greater the PTSD system. It's a linear relationship. Look at the R value is 0.84. It's almost 1. It's almost like 1-to-1 relationship. It's very significant. So the hippocampus is really critical. Now, when hippocampus function is compromised, word recall, memory recall become a key function that's lost with them. Left hippocampus issues, they have problem with directions and numbers. Right hippocampus generation, they have problem with, left hippocampus, they have problem with numbers. Right hippocampus, they have problem with directions and locations and finding things. So you'll see some issues with that as well. And another pathway for these circuits to be involved, or these reduced hypothalamus spinal tract activity, just like brain injury, brain activity, loss of function in general. When the brain activity in general gets compromised, you can have increased responses. Typically what the brain does is the different regions of the brain, the frontal cortex, the parietal cortex, the occipital cortex, the temporal cortex, they all get activated and they fire into the brainstem. As they fire into the brainstem, they activate the hypothalamic spinal tract. These hypothalamic spinal tracts excite inhibition of the intermediate cell column, they dampen sympathetic. But when the brain is not functioning with brain injury or just low blood sugar states or hypoxia or neurodegeneration, there's inability to activate these hypothalamic pathways. So there's increased sympathetic tone and there's this chronic anxiety. So you see high blood pressure, you see dilated pupils, you'll see that pattern with many people have sympathetic responses. And one of the things you have to do as a clinician when you're working with people that have anxiety is their anxiety metabolic or is it neurological? Now, when we get to the physical examination of the course, I'm going to teach you how to find neurological induced anxiety. If it's not neurological based, then it's metabolic. Okay? So you got to know these pathways so then you know how you can evaluate them in a physical examination. Now, those are the key things with anxiety pathways as we talk about circuits. And then we have bipolar circuits. And remember, with bipolar circuits, all these different areas of the limbic system are not functioning together. There's a genetic susceptibility with white matter abnormalities, with limbic network damages. And once these network damages take place, this leads to mania and depression and the condition itself. So damage to the limbic networks is the key pathophysiology of bipolar disorder, and they're triggered by inflammatory responses. So when we look at the neurological mechanisms of mood, and we talked about regions already, but now we're talking about circuits. And we went over depression circuits and anxiety circuits and bipolar circuits. These circuits can all be compromised by these four main things: brain injury, vascular injury, demyelination, or hypoxia. Okay? So let's go over some of these mechanisms as well. So a lot of people have anxiety because their limbic circuit is injured. A lot of people have anxiety because they have neurodegeneration. A lot of people have depression because their frontal lobe is not healthy. So to jump into a random set of nutraceutical protocols, or just go, just fix the gut, and assume everything's going to be fixed is inefficient. Okay? Now, let's start with demyelination. So your limbic circuits, these pathways for the basic ganglia, that dampen the amygdala, or pathways that activate the frontal cortex so we're not depressed, or pathways from the cerebellum that fire into the sympathetic centers that can happen with celiac disease that cause anxiety, they can be injured. One pathway that can be injured is demyelination. So autoimmune viral, anytime you see any kind of neurological deficit, any signs of autoimmunity, neurological autoimmunity, you got to consider that. And here's a paper that was published, Mood Disorders as a Presentation Manifestation of Demyelination. On organic basis for psychiatric disorders often overlooked. Children presenting with symptoms suggestive mood disorder, declining cognition, or psychosis deserve a detailed neurological examination. Yes, they do. They deserve a detailed neurological examination. And appropriate imaging if indicated before starting them on antidepressants and neuroleptic medication. Right? Like, for God's sake, do an exam, do a workup. Like, that's basic, it's fundamental. The reason we have such a problem is because we have clinicians that do not know how to critically think, and they think they do because somehow they went through an academic rigorous program, but they actually have no real clinical diagnostic skills. They don't know how to do a physical exam. That's gone years after they first learned it. And then they just hand out this stuff like it's candy. And they never actually get the diagnosis. So there are people that have subtle demyelinated patterns that aren't full-blown MS. Here's another paper. Patients with multiple sclerosis frequently experience depressive and anxiety symptoms, including cognitive impairments. So these are the main autoantibodies you should always check. This is the list. If you suspect their mood disorder may be autoimmune, whether it's major, minor mood depression, or it's general anxiety disorder, or it's social phobia, it doesn't really matter. These are the key pathways you want to check. Now, for some person, their hippocampus pathways that are involved to their amygdala gets activated, and their demyelination causes social phobias. For someone else, their demyelination injures their hippocampus, and now they're more prone to PTSD, and the PTSD gets worse. So the mood disorder is just caused by injury to the different pathways of the limbic system itself, not as independent things, okay? Another one is vascular insult, silent strokes, microvascular disease, acute onset of symptoms. All of a sudden, you should always think of vascular. And this is a paper that was published, and they go on to say that microvascular dysfunction may be an early targetable mechanism in the development of depression, notably depression that initiates in late life, late onset depression. Late onset depression commonly co-occurs with other diseases or syndromes that may share microvascular origin, including apathy, cognitive impairments, dementia, and stroke. So easy to find, simple MRI. You see all these different indications of microvascular disease when it occurs. I'll show you some imaging studies later. And then limbic vasculature, these little arteries that go into the basic ganglia that dampen the amygdala, the lenticulostrial arteries, really common to burst with hypertension. Many people that have hypertension get little microstrokes in there. They get chronic anxiety disorders. Get little lacunes, strokes. These are white matter hyperintensities. Blood flow to the myelin sheaths get involved. But anytime you see hypertension, diabetes, obesity, smoking, sedentary lifestyle, elevated homocysteine, just poor vascular health, you should always suspect vascular involvement and stepwise deterioration. And then traumatic brain injury, symptoms may occur directly after injury 2 years later. Remember that, like people that have head injuries, their symptoms come in years and years later. They don't happen right after the injury. So the key understanding of chronic traumatic encephalopathy is that people get a head injury, their glial cells get activated and inflamed, this forest fire spreads and spreads and spreads, and at some point they get enough inflammation and injury where they start to have symptoms. And that could be 5 years, it could be 20 years. So you have to be aware of that. Now, the biggest clue of a serious brain injury is loss of consciousness. Loss of consciousness is a big deal. So if anyone's ever had a sports injury where they lost conscious or had multiple head injuries, you could have injury into these limbic circuits over a period of time get expressed from that chronic inflammation leading to a mood disorder. So that's really, really important. And in those cases, you just have to improve the health of the brain and look at all the things we talk about in the neuroinflammation core strategies to dampen their prime glial cells. Now, traumatic brain injuries in this paper, they go on to say, are associated with increased risk of behavioral emotional dysregulation, such as agitation, aggression, personality changes, as well as increased risk of subsequent mood disorders, namely depression. With football players that have gotten a lot of attention in the news recently, where they get this chronic traumatic encephalopathy, the main symptoms are really aggression, irritability, anxiety, anger, suicide. They can't control it. And if you can get in there and get their brain healthy, dampen their neuroinflammation, improve the blood-brain barrier, improve their brain gut access, get their blood sugar levels stable, get them on healthy amounts of signaling compounds like essential fatty acids to help with neurotransmission and other things, you can make a huge difference in their mood disorder, but you're not treating it as a serotonin deficiency or something like that. And then hypoxic injuries like near drowning, carbon monoxide poisoning, cardiac arrest, hemorrhagic shock, septic shock, acute lung injury, these can all lead into mood disorders. In recent years, several pieces of evidence have highlighted the effects of hypoxic injury and neuroplasticity and pathogenesis treatment of mood disorders. So you always want to look into your history for those types of things. Because in reality, you may have someone who has a chronic mood disorder, and before you think it's just this complex metabolic thing with the thyroid and various species of the microbiome that impact their mood, it could just be injury to their limbic circuits. And that's the main reason why they have this chronic pattern. So you don't want to neglect the fact that sometimes these circuits themselves get injured. Now, we talked about regions, we talked about circuits. Let's go into the actual cells in the limbic regions. And within the cells of the limbic regions, we're talking about neurons, microglia, astrocytes, and vascular endothelial cells. And the very first thing to talk about is that these cells need to function, and they need ATP and energy to function. So mitochondrial deficits can really impact neurons, microglia, astrocytes, and even vascular endothelial cells. We'll just focus on the neurological cells in the brain first. So, neurons, astrocytes, microglia, oligodendrocytes, they're all involved with essential pathways to make sure that we have healthy brain function and healthy mood. Signaling pathways, connectivity for neurons, astrocytes also help with synaptic cleft modulation of neurotransmitters, brain barrier permeability. Glia get rid of debris that gets in the way of healthy neurotransmission. They help create an anti-inflammatory state when they're expressed as an M2 pathway. They clean up synaptic branches that are inefficient to make signaling pathways more efficient, and oligodendrocytes, which is basically involved with the myelin sheath. These all require ATP. So if these specific cells in the region of the limbic system are not healthy, then you can have some significant mood disorders. Now, your biggest clue that you have a person that has mitochondria cellular involvements of mood disorders is the following. The mood disorders are triggered from activities. So the clinical profiles mood disorders that are triggered from activities suggest unhealthy mitochondria in cells of the limbic system. So fatigue causes their depression. If fatigue causes their anxiety, you know that the cells in the limbic circuits are involved. And you got to get that mitochondria activity up. So remember that as a person gets oxygen, glucose stimulation, has ability to dampen oxidative stress inflammation, they have healthy mitochondria make ATP. That helps them with their neuron endurance and also helps their neurons be far away from threshold. When the mitochondria become impaired from deprivation of the key things they need, like glucose oxygen stimulation or too much inflammation. They have less ATP, so they have very poor endurance, and they need trivial amounts of input to get to threshold. So you can see like shining a light in their eye can cause them to have anxiety all of a sudden, and they start tearing, and their brain gets tired, and it's just a major problem. So anytime you see mood disorders that are triggered from activities that suggest unhealthy mitochondrial cells of the brain. Now, types of brain stimulation for limbic circuits that you can suggest may have mitochondrial issues are social interactions. They get and talk with someone for 2 minutes, their brain is totally toast. Now they have depression, now they have anxiety, now they have both. Critical thinking, problem solving is just way too much for them. It just shuts down their brain. They can't think, they can't focus. Executive functions, if they have anything where these tasks immediately shut down, associated with their mood disorder, then you know their limbic circuit mitochondria is off. If their cerebellar pathways are involved, because remember the cerebellum is injured, can't gate input from the vestibular system efficiently, so people have their sympathetic amygdala pathways activated. If they get immediate fatigue and anxiety or depression from driving, lots of movements in the background, or even if they say movies with lots of screen changes, that can be an issue with their mitochondria and their cerebellar limbic circuits, crowded places. And then sound or lights that are high pitch really indicate that these midbrain circuits are overactive. So here's a list of things that clue you into the mitochondria being unhealthy. So you could have people that have mood disorders because their limbic circuit mitochondria are unhealthy. All these various triggers can cause mitochondrial cells to be unhealthy. These all impact ATP function in cells in the limbic region, neurons, microglia, astrocytes. These can cause mood disorders. This is a diagram that I made for a paper that I published, Physical Medicine and Rehabilitation, just a couple months ago. And it's just a chart I made that shows all the things that in green that help this pathway of mitochondrial activity, and red which decrease it. So just to review the literature. It's all simplified in one chart. I just thought that might be a good quick summary. If you went to the Crosby Institute Energy and Fatigue and Pain course that we taught, we went over these concepts in great detail. Okay, so we know we have mood disorders that may be mitochondrial linked when they have poor endurance and very trivial types of stimulation impact them. Then we know that these limbic region cells, these mitochondria cells, the mitochondria within these cells are involved. Now we can also have issues with mood disorders when the vascular endothelium is involved. So if there's unhealthy blood flow dynamics that are happening, getting blood flow to the cells in the region, we can also have neuron dysfunction, microglial activation, and mood disorders. So blood vessel health is really, really important. So looking at someone's blood pressure, looking at someone's temperature, their fingernail, their nail bed should be pink, they should have lots of healthy color, they should have warm limbs, their blood pressure should be under control. Those things that are dysfunctioning, then you may have a blood flow dynamic mechanism where these cells aren't getting proper circulation where they can function. And then once we go from cells in the limbic region, these cells are really responsible for function, and we can't just have dysfunction in them itself. So let me kind of recap what we've talked about. We talked about these limbic regions could be atrophied or not developed. You could have limbic circuits, which could have vascular injury or demyelinization. We can have cells in the limbic region not functioning because they don't have enough healthy mitochondrial ATP activity, and then these cells may have those proper mitochondrial activities, but their functions themselves may be where the problem is. And then these involve things like the synapse, neuroimmune activity, blood-brain barrier function, cerebral circulation, neuron plasticity. Okay, these are all other factors. So let's go over neurochemical synapses first. So, ultimately, when you look at any kind of mood function, it's a combination of different neurotransmitters working in the areas of the limbic system to then impact mood, cognition, energy, interest, and so forth. Epinephrine, serotonin, and dopamine, you can see in this illustration, are really involved with mood, cognition, learning, and positive effects here, right? Now, when you look at the synapse and you look at these neurotransmitter dysfunction and balances, you have to realize that there's three requirements for a synapse. There has to be a proper synthesis and release of a neurotransmitter in the neuron. Okay, so the neurotransmitter has to get in there. You have to have healthy amounts of precursor amino acids, nutrients, cofactors, oxygen, glucose, vitamins to make neurotransmitters, and then they're released. And then once the neurotransmitter is released, the neurotransmitter has to bind to the receptor site. And then there's the concept called homotropic, heterotropic modulation, and receptor site sensitization. Homotropic modulation means the same neurotransmitter dampens its own receptor site to prevent overstimulation. Heterotropic modulation means suppressed presynaptic release of other neurotransmitters. And basically what that means is one neurotransmitter by itself bind with another neurotransmitter may have a different effect. Or receptor sites can be sensitized. For example, progesterone can sensitize GABA receptors, right? Valeric acid from valerian root can sensitize GABA receptors. That's the area of receptor site sensitization. So those are all part of receptor site postsynaptic functions. And then the termination of the signal is critical. Once these neurotransmitter substances get into the synaptic cleft, they have to be cleared out of the way so that new ones can be released and then bind to the receptor sites. So this reuptake mechanism is really critical, and this degradation pathway is really critical. And those are the key things that we have to deal with when we look at neurotransmitter responses. So you could have things that impact neurotransmitter synthesis, things that impact the receptor sites of signaling pathways, like other hormones or other neurotransmitters or different natural compounds. And then we have to have reuptake and cleft degradation pathways, and certain things can impact those as well. We'll talk about those with treatment and nutraceuticals. Now, another key concept to understand is when you look at a neuron, neurons are going to be set to a state of either sodium equilibrium potential, or what they call a central integrative state, towards activation, excitation. So what you see here is you see more positive inputs going to a neuron than negative. Positive is green, negative is yellow. So this means the neuron's going to get excited as an excitatory pathway. And then if you look at this one, the central integrative state is inhibitory, because you have more inhibitory projections than positive to a neuron. And this neuron is important because, again, some of these pathways could be serotonin, some of these pathways could be GABA. So let's say the negative ones are all GABA pathways, the green ones are serotonin. So even though someone takes serotonin support, maybe GABA activity has a different impact on them based on how the limbic system is functioning. Now when you look at excitatory versus inhibitory neurotransmitters, epinephrine, norepinephrine, dopamine, acetylcholine, serotonin, these all promote depolarization. They're called excitatory. The main inhibitory neurotransmitter we have is GABA. Okay? Now here's an important concept. Excitatory neurotransmitter plus an excitatory neuronal pathway equals excitation, activates. Inhibitory neurotransmitter of an excitatory pathway equals inhibition, it calms down. Excitatory neurotransmitter of inhibitory sensory pathway causes inhibition, things calm down. An inhibitory neurotransmitter of inhibitory pathway causes excitation. So why do I say this? So for example, someone may take dopamine or serotonin, let's just say serotonin, which is excitatory, but the serotonin activates an inhibitory pathway, like the basic ganglia indirect pathway, and all of a sudden it calms them down. So some people with anxiety actually take a serotonin uptake inhibitor, which increases synaptic cleft activity of serotonin longer, but it actually calms them down. So they're having excitation of an inhibitory pathway projected. Other people may take an inhibitory pathway, like so some kind of GABA nutraceutical or anxiolytic or something like that, and let's say passion flower extract, which has GABA binding receptor activity. But if for them, their inhibitory pathways get activated with them, it can actually excite them. So you'll see some people take nutraceuticals that are supposed to calm them down, but the way their limbic system and pathways are integrated or injured or functioning, they can have a counter or paradoxical response, I should say. They can have a paradox response where their inhibitory compound is actually causing excitation. And there's also these variations in receptors. There's 5 different dopamine receptors. There's a list of serotonin receptors. There's A, B, and C GABA receptors. There's actually different variations of A, B, and C. There's actually 24 different GABA receptors. So different substances have unpredictable responses with people. And sometimes when you're dealing with neurotransmitters, you can be all over the place. Now, altered neurochemical synapses like dopaminergic activity, acetylcholine activity, serotonin activity, GABA activity, epinephrine orbital activity can lead to mood disorders. And this was the initial monoamine model. It's for sure part of the circuits involved with the limbic region, but it's not the only model. And this is, so meaning like, it's still important, but it's not as important that we used to think it was. So we'll talk about that as well as we get into research and applications. Now, here's the dopamine pathway. Let's start with dopamine. Dopamine pathways are really critical. There's a nuclei in the brain called the nucleus accumbens. Nucleus accumbens has a pathway called the ventral ascending dopaminergic system. And the ventral ascending dopaminergic system floods the brain with dopamine, which causes reward and motivation and drive. This ventral ascending dopaminergic system is what causes gambling addiction and exercise addiction and so forth. And some people that have addiction personalities, they need to activate this ventral dopaminergic system all the time in order to function properly. But in non-extreme cases, this nucleus accumbens pathway activates the frontal cortex. And movement and exercise, especially complex integrated movement, really activates these pathways to really flood the brain with dopamine. And dopamine is necessary for motivation, reward, emotions, helps with executive functions because it activates the prefrontal cortex. But I also want to point out to you that dopamine is made in all these different cells in the brain. Here you see blood-brain barrier. Everything up here is dopamine levels made in the brain. And then dopamine is made in the peripheral nervous system, in the adrenal medulla, and in the kidney proximal tubule. So if you do a urinary dopamine test, you're seeing this. You're not seeing this. You're not seeing dopamine levels in a certain cell in the region of the brain showing up on urine. You're measuring this, which is independent of that function there. Okay. Now, when people have low dopamine activity, the typical things is worthlessness, hopelessness, inability to finish tasks, inability to start tasks. That's the main thing. Now, we have a questionnaire form that we'll go over later that tells you how to look for dysfunctions in certain pathways, like the dopamine, serotonin, GABA pathway, acetylcholine pathway, and so forth. Now, dopamine is synthesized through dietary consumption of proteins. You get phenylalanine. Phenylalanine gets N-acetylcysteine. And then large neutral amino acid transporter activates the transport of N-acetyltyrosine across the blood-brain barrier to get tyrosine into the brain. And then tyrosine gets converted by tyrosine hydroxylase to DOPA, and then DOPA gets converted into dopamine by B6 and oxygen, iron, folic acid. These are the cofactors. The most important part of this pathway is this insulin to branched chain amino acid ratio. There has to be proper insulin responses to activate large neutral amino acid transporter to start dopamine synthesis. So when people have blood sugar issues, they can have deficits in their ability to make dopamine. If people are anemic, people have severe iron deficiencies, B6 deficiencies, their dopaminergic synthesis may be impaired, okay? Now, if we get into acetylcholine, you can see the nucleus basis basalis here, pediculopontine and pedicular nucleus. These are different paths, these nuclei that make acetylcholine. So here's all the different acetylcholine in the brain, see above the blood-brain barrier, that's synthesized acetylcholine. And then acetylcholine is made in the enteric nervous system and smooth muscles, dorsal ganglia, autonomic nervous system. Levels measured in urine do not reflect what's happening in brain. And the key thing when the acetylcholine pathways are down is just loss of visual memory, loss of cognitive episodes, numbers, calculating. Becomes difficult. Remembering objects and faces, directions become a problem. And acetylcholine synthesis involves dietary consumption of choline. So you have to have choline in your diet to make acetylcholine. So like egg yolks, really high source of choline, for example. And if you don't have choline from your diet, what basically happens is your cell membranes break off and get broken down from lack of dietary choline, breakdown of cell membranes and phospholipids in the brain to provide choline, so you can make acetylcholine. So healthy sources of organ meats, egg yolks, animal fats, these provide choline. And if you don't have enough from them, then you have breakdown of membranes. But that's how acetylcholine gets produced. So it's really highly dependent upon choline intake. And then serotonin is involved with pain, aggression, mood, sleep-wake cycles, appetite, joy. And there's different nuclei in the brain that make serotonin that have direct projections to those areas of the brain. And then serotonin is made in the GI enteric nervous system and the proximal tubules, the kidneys, the platelets. So urinary serotonin levels really reflect these levels and nothing to do with brain. And the main symptom of low serotonin is just no joy. People that have low serotonin, they're like, you go, hey, you want to go to a restaurant? What do you want to eat? I don't care. You listen to a song? What do you want to listen to? I don't care. Like the songs they like, the music they like, the hobbies they liked, no longer bring them joy. It's a very characteristic pattern of low serotonergic activity. And serotonin also involves protein consumption, breakdown of the protein into branched-chain amino acids, leucine, valine, isoleucine, stimulates insulin. And this proper insulin response stimulates this large neutral amino acid transporter, LNA, to carry tryptophan across to the blood-brain barrier, where then iron and folic acid and magnesium, methylcobalamin, B12 all convert to serotonin. So if someone has dysglycemia, their serotonin pathway synthesis becomes a problem. Someone's severely iron deficient. Someone has significant folate issues or B12 issues can have issues with serotonin efficiency. Not that that doesn't get made, it's just not as efficient. And then the GABA pathways. GABA is not made by any nuclei in the brain. GABA is made in all neurons. And there's this recycling of glutamate to GABA happening at neurons all the time. So they're circulating glutamine, glutamine converted to glutamate, glutamate is excitatory, glutamate then gets converted into GABA, and then GABA is inhibitory. So there's this cycle of how your neurons can make their own excitatory glutamate or their inhibitory GABA as a way to balance out cell signaling pathways. So you can see here GABAergic neuron, glutamergic neuron, and then these energy pathways being shunt within the cells. So this is all cellular. It's not dependent upon any nuclei. That's how GABA is different, and glutamate's different. And basically, if GABA activity is reduced, people just feel anxiety, nervousness, knot in their stomach, because the main pathways in the brain that inhibit the amygdala involve GABA. And then norepinephrine, epinephrine are really involved with attention, arousal, focus, concentration, cognitive function. And there's areas in the brain, specifically the locus coeruleus in the brain, that is involved with producing epinephrine, and it directly activates those regions of the brain of the frontal cortex and different regions for its catecholamine response. But then catecholamines are also produced by the adrenal medulla. So urinary epinephrine, norepinephrine is really adrenal function. The levels, they don't reflect levels happening in the brain. And people's catecholamine activity is depressed, and those projections to the frontal lobe are not functioning. They get depression, but they also have depression with mental alertness, speed issues, cognitive issues, and so forth. So if you see someone who's got depression, and they also have inability to initiate, activate, and do things, that's dopamine. Someone has depression and they have no joy in anything, that's more serotonin. Someone has depression and anxiety, that could be GABA. Someone has depression and their verbal memory is gone, that could be more of an acetylcholine issue. So any one of these neurotransmitters, anything that decreases the frequency of firing of the prefrontal cortex can cause depression. So sometimes when you look at all these different symptoms, you get a clue what's going on. Now, you can also see, for example, when we look at catecholamine synthesis, once again, we need to get this large neutral amino acid transporter to take digested proteins across, and we need iron, folic acid, oxygen to allow these catecholamine synthesis to take place. So you could have someone who has severe anemia or hypoxia, or dysglycemia, really throw off their catecholamine synthesis. So those are things we'll talk about when we get into nutraceutical applications. But we've gone over the neurology, the limbic regions, the limbic circuits, the cells. Now we're looking at functions, and one of the functions that the cells do is the synapse. Okay. Now let's move from the synapse into neuroimmune activity. So when we look at cellular dysfunction limbic regions, we know that if these dopamine, acetylcholine, serotonin, GABA, or norepinephrine pathways are disrupted by things like lack of oxygen, anemia, which is carrying oxygen to these cells in the brain, or severe iron deficiency anemias, or dysglycemias that impact large neutral amino acid transporter, those can alter neurochemical synapses. But we can also have upregulated neuroimmune activity impact mood disorders as well. So let's talk about the neuroimmune response. So here you see some peripheral inflammation being activated. Here it says stress or early life adversity, whatever the scenario may be. But the concept is there's peripheral inflammation. That peripheral inflammation basically crosses into the brain and it activates the glial cells, and these glial cells then alter serotonin metabolism, they alter glutamate pathways promote excitotoxicity, create oxidative stress, and these things have been associated with mood disorders. Now, we know that peripheral inflammation can get into the brain, inflammatory cytokines can get into the brain through different pathways. They can just diffuse across a blood-brain barrier. They can see here, especially if it's permeable. They can go through the vagal afferent pathways. They can bind to endothelial cells and get across, or they can go through active transport pathways. Those are all listed here. We talked about this in great detail in the neuroinflammation course. But the bottom line is that peripheral inflammatory responses can get into the brain and activate the glial cells in the brain and the microglia and the astroglia of the brain, and they can induce mood changes. So a lot of mood changes are really due to systemic inflammation. And more research keeps coming out showing that this is the central pathway. And like I showed you earlier, they found like even the acute response to antidepressants seem to be that it has an anti-inflammatory effect. And ketamine, the new drug being used with unresponsive depressive patients, that's also showing to have an anti-inflammatory effect. So, what we see all the time are people that are chronic, that have chronic inflammatory pathways. Here's just a list of things that cause brain inflammation, whether it's like uncontrolled diabetes with high HbA1c or gut permeability or gluten sensitivity. These things can all lead to neuroinflammatory responses. The main symptoms of neuroinflammation is brain fog, unclear thoughts, poor brain endurance because it uncouples the mitochondria, slower brain, varied mental speeds. These are all part of that mitochondrial, the neuroinflammatory pathway. And here you can see that inflammation directly causes synaptic dysfunction. You can see that here they show glial cells, microphyte glia, activated prime glial cells. When inflammation comes in from the periphery, they turn on inflammatory messengers that basically disrupt synaptic activity. The synaptic synthesis, the clearance pathways, the elimination, and things that activate BDNF and plastic responses. Those are all impacted with inflammatory response in the brain. And when they look at the neuroimmune mechanisms and treatment protocols for depression, this is what they find is some of these initial acute responses to antidepressants may have these anti-inflammatory effects. That it's really more of a neuroimmune issue than is a neurotransmitter imbalance in the first place. Now, this was the paper that was published saying, exploring the potential antidepressant mechanism of TNF-alpha, and they went on to say that numerous reports point towards the effectiveness of anti-TNF-alpha drugs for some depressant patients, which is an anti-inflammatory, very powerful anti-inflammatory. Use of TNF-alpha antagonists as antidepressants may be particularly important for subpopulation of patients with treatment-resistant depression that show high levels of expression of pro-inflammatory cytokines. So based on all the evidence that's coming out, now there's many university psychology, psychiatry departments that are really looking at maybe we need to be treating depression with anti-inflammatories than antidepressant, which impact neurotransmitters. And here you can see a really good illustration of immune activation of depression. They show like a cold or flu, some kind of sickness, some kind of chronic inflammatory condition. Here they show like rheumatoid arthritis. This creates pro-inflammatory cytokines. These pro-inflammatory cytokines alter synaptic plasticity. You get neurodegeneration or even lack of neuroplasticity. Then you get depression. And then in research studies, they can look at like things like in high S100B. S100B, as you know, is a marker for surrogate marker for blood-brain breakdown, activation of the astroglial cells. High S100B levels predict antidepressant response in patients with major depression, even when considering inflammatory and metabolic markers. So the higher the S100B response, the greater depression they have, and the less responsive they'll be to any kind of monoamine depression medication. And then this is the paper called Immunoregulation Antidepressant Effects of Ketamine. In addition to acting as a classic receptor and rapidly changing neuroplasticity, ketamine also improves depressive symptoms through immune regulation, including regulation of peripheral cytokines and central glial cells. So you can see, it's very well known that these inflammatory pathways are involved with inflammation. Now, when we look at these inflammatory pathways, the most popular one is this kynurenine pathway. And with this kynurenine pathway, anything that activates the microglia, whether it's from the lung-gut axis, the oral mucosa, the microbiome, breakdown of the blood-brain barrier, any kind of systemic inflammation that turns on microglia, that can cause activation of this kynurenine pathway. And here you can see this mechanism. So here you can see like tryptophan metabolism, and you can see tryptophan gets converted to serotonin. That's pretty obvious. And that's the neurotransmitter response. But also tryptophan can go down this IDO pathway, this enzyme called IDO, and then it can become kynuric acid. And kynuric acid has an anticonvulsant, anti-anxiety, toxic effect. This is why ketogenic diets help with seizures, because ketogenic diets activate this kynuric acid and calm down seizure activity. Now, if you have too much, it's not a good thing, but with a ketogenic diet, you're not gonna have too much. But there are some people now that are not getting the best response with seizures with ketogenic diets, and they're adding tryptophan to their protocol to really amplify this pathway, which seems to be effective in some subjects. And then the other thing that happens with this kynurenine pathway is this inflammatory pathway, where this IDO expression, instead of going to serotonin, causes immune activation, and you make this thing called quinolate acid. And quinolate acid is an excitotoxin. And this excitotoxin damages the brain. And when they look at depression, what they can see is this, in major depressive disorders, very high levels of this inflammatory quinolate acid. And even with some depression disorders, the kynuric acid, which shuts down neurons, to be very, very active. So, this kynurenine pathway, which is involved with inflammation, the concept is immune activation, inflammatory responses activate IDO, and tryptophan, instead of going to serotonin, goes down these quinolinic acid neurotoxicity pathways and causes injury to the brain. And this is where neurogenesis, synaptic plasticity can be impacted, neurotoxicity takes place, serotonin transmission takes place, and you can get mood alterations and cognition and cognitive dysfunctions there. Then you have these glial cells. There's another module for neuroinflammation, and activated glial cells are a key issue. And remember, glial cells can have a pro-inflammatory response or an anti-inflammatory response. And there's a balance between M1 and M2 pathways. And people that are smokers, that have inflammatory conditions, have hypoxia, lack of antioxidants, promote this M1 pathway, and that creates chronic inflammation. So in addition to anything that causes microglial activation periphery, causing the kynurenine pathway to be activated, this also activates the microglia into a pro-inflammatory state. And you get decreased nerve conductance, tau protein aggregation, vascular inflammation, and mitochondrial uncoupling. The key thing with the microglia is if it becomes primed. So if the inflammation is severe enough, whether it's a viral infection that gets into the brain or traumatic brain injury, glial cells, which normally have these ramified projections, these legs that move around and transport and engulf protein debris, start to lose their legs and go from a ramifoid anatomical structure to an ambioid structure. And then these glial cells become hyperactive and stay in the region that they're involved. And once they're developed, they can't go back. It's like a hard-boiled egg. Once you get different changes in the proteins, they're not going back. So these prime glial cells become permanent. So over a period of time, when people get chronic inflammation to the brain and start to activate their glial cell systems, they can get this chronic inflammatory response in the brain. And when their glial cells are primed, it's like that second hit that causes a problem. Like in the world of boxing, there's a common phenomenon known that once a person that's like a guy that's never been knocked out his entire career first gets knocked out for the first time, then after that they always get knocked out. Because that first hit actually injures their brain. Those glial cells are activated, and it takes very little activity to get that inflammatory pathway triggered again. So even low impacts can cause a problem for them. Now, it could be, instead of being traumatic, it could be even neurochemical, emotional traumas to the brain can prime glial cells. In some studies, that's suggested. But for sure, from inflammatory mediators. So inflammatory mediators can activate these glial cells. They can be primed, and they can cause depression, anxiety, and so forth. Here's an illustration of microglia in a petri dish where they're being stimulated by lipopolysaccharides. Lipopolysaccharides are things that happen with leaky gut and endotoxemia. So if someone has dysbiosis, and then they also get leaky gut, the dysbiotic bacteria produce a postbiotic called lipopolysaccharide, gram-negative lipopolysaccharide, and that can get into the blood-brain barrier and cause some activation. Here's microglial cells before LPS activation. They're moving around, they have their legs, they're functioning, everything's good. And then all of a sudden, someone gets leaky gut and endotoxemia, these LPS levels activate microglia in the brain, and you can see that they lose their legs, and they become kind of like permanent structures there. And they cause all types of inflammatory reactions that then cause depression and mood changes. So clinical pearl, a magnified inflammatory response. So an inflammatory suggests primed microglial cells. So I just made a list of things, of mechanisms that reactivated primed glial cells. We really go to this in much more detail in the neuroinflammation course. And then with people that have primed glial cells, the more subtle symptoms is brain fog. As they get more severe inflammation, that's when depression comes in and sleepiness comes in and lethargy and fatigue. So for some people, it's a significant neuroinflammation that causes it. Now, if the glial cells are primed, then it takes very little inflammation for them to get into severe inflammatory states in the brain. And that's the key thing. So always look at when you see like someone has an exposure to an inflammatory trigger, all of a sudden have severe depression and can get out of bed, you got to look back for brain injury, whether it was like a viral infection or actual mechanical trauma to the brain, and then you have to treat it as a neuroinflammatory primed glial cell to deal with their depression. Now, in addition to upregulated neuroimmune activity causing cellular limbic region dysfunctions, there's also astrocyte dysfunctions that take place unrelated to glia, the astrocytes. So the astrocytes are part of the blood-brain barrier, but the astrocytes, you can see on the left, modulate the glutamate and GABA response between the presynaptic neuron and postsynaptic neuron. Here you can see the microglia. And when there's an inflammatory response in the brain, this balancing out of glutamate and GABA by the astrocytes become dysfunctional. And here you can see even other things that take place with inflammation in the brain. Here's a normal glial neuron interaction. Here you see the astrocyte, here you see the microglia, here you see the nerve synapse. Here's the synaptic cleft. So the neurotransmitters are in between the way. The astrocyte helps modulate glutamate GABA neurotransmitter responses with excitatory and inhibitory pathways. And the astrocyte also helps release things like growth factors, GDNF, BDNF, these are nerve growth factors, helps with ATP production, and keeps everything nice and healthy. Blood-brain barrier is healthy, it's impermeable, it's intact. And then when there's inflammation in the brain, then the blood-brain barrier opens up, macrophages come in, inflammatory cytokines get released, ATP levels go down, then there's reduced reduction of growth factors, and the whole synaptic dysfunction takes place. So this is why many researchers are also just looking at chronic depression, major depressive disorders, really being inflammatory. And then the other thing that happens in mood disorders is this excessive pruning. Pruning is the neuron process of cleaning up synapses, so it's healthier and more efficient. But what happens with inflammation is these glial cells have excessive pruning. They get rid of too many branches, and then that leads to reduced connectivity, and that can lead to depression and mood disorders. And then there's lots of research with the blood-brain barrier permeability being a factor. There's some studies you can look at on your own there. There's some illustrations of blood-brain barrier permeability here. And I also made a chart for you of all the various things that cause the blood-brain barrier to break down. And here's a study where they show a nice illustration of blood-brain barrier breakdown, damaged neurons, and the promotion of major depressive disorder from a leaky blood-brain barrier. And in addition to the blood-brain barrier, just lack of blood flow to the brain. You can see an imaging study where you can see with people that have major depressive disorder, they're just not getting healthy blood flow. So this is, compare blood flow here nice and red, impaired blood flow here with person with depression. So lots of researchers now showing poor circulation, poor blood flow, things like hypertension, unhealthy vascular endotheliums can lead to late onset depression. Blood pressure fluctuations, arterial stiffening from high blood pressure can lead to damage to the blood vessels in the limbic system, then can lead into depression. There's even a term that's being now used called vascular depression. Now, this is just a chart that shows the things between a healthy endothelium and dysfunctional endothelium. We did an entire course on cardiovascular disease where we talked about how to make the endothelium healthy. We don't have time to go through all those concepts. and what labs you can use to make the endothelium healthy. But if you see someone who's got like peripheral arterial disease and cold hands and cold feet and the circulation's really bad, you definitely want to consider, if they have major depressive disorder, to go down this vascular pathway. And the first sign of vascular dysfunction and poor circulation is low nitric oxide. And that's when you see a tendency for blood pressure to go up, or if their blood pressure is normal, if their blood pressure is low, they'll say, hey, I'm getting sicker, but my blood pressure is improving. It's not that their blood pressure is improving, it's that their nitric oxide levels are going down in their blood vessels. So it looks like they're getting to be more normal, but they're actually getting more injured. So be aware of that with people that have low blood pressure the whole life and all of a sudden feel like they're getting normal, but they're actually getting sicker. They're actually getting their vascular endothelium impacted. And then there's neuroplasticity pathways. And neuroplasticity pathways are just pathways where neurons can connect with each other. They can reorganize. And there's lots of research that really shows that neuroplasticity is really the main pathway where these connectivity pathways that are so necessary for healthy brain function take place. In order to have healthy synaptogenicity and plasticity, you have to have lots of fuel for your mitochondria, oxygen, glucose. So you can't be anemic, you have healthy lung function, healthy red blood cells. To have healthy mitochondrial biogenesis, BDNF, reduce neuroinflammation, and then all these things help relate to synaptic plasticity. And synaptic plasticity is basically the concept of neurons branching over to each other. So ketamine, the new drug, is shown to activate BDNF, which does this for a short period of time, and it gets them out of depression. And here you can see an illustration of plasticity, neuroconnectivity. So now they're linking chronic mood disorders that don't respond before they get neurodegenerative diseases, really having impairments of their neuroplasticity. And neuroplasticity involves 4 requirements. You have to have a healthy mitochondria, and the mitochondrial biogenesis, development of mitochondria. You gotta have healthy fuel to the mitochondria, like glucose, oxygen. You gotta do things that support mitochondrial biogenesis, like fasting, exercise, cognitive activities, high antioxidant diet. Avoid things that impair mitochondrial biogenesis, like sedentary lifestyle, inflammation, excess calories. And then you have to have release of BDNF. BDNF is the growth factor that involves neuron connection. The main things that impact neuron connectivity are physical activity, mental stimulation, social interactions. Those are the main ones. And the stress and lack of activity deprive the cells of releasing BDNF. So this BDNF response is involved, and then finally have pruning. So those are the key things for plasticity. So to put it all together, you want to look at mood disorders as not an independent individual thing. Mood disorders is something's wrong in the limbic system. It could be, and lots of things can go wrong in the limbic system. Okay, the regions themselves could have developmental delays or atrophy for mechanisms. The circuits themselves could be injured. There could be vascular insults, there could be demyelinization, there could be hypoxia. The cells could be dysfunctioning because the mitochondria is not working. Their blood vessel and endothelial function stiff, not getting enough blood flow there. Or there could be individual neurochemical imbalances that are leading to these mood disorders. And then here what I did is just summarized with the last 3 slides here. I summarized things that happen with cellular dysfunctions in the limbic regions that we went over, but specific to each type of mood disorder. So for depression, lack of these neurotransmitter responses, lack of increased neuroinflammation, impaired neuron microglial mitochondrial function, impaired cerebral circulation, impaired plasticity. All these things can decrease activation of prefrontal cortex and lead to major depressive disorder. And our only focus here is depression that's chronic and long-term and doesn't respond to anything. These are the things you think about. And for anxiety, you can have anxiety if there's increased activation of the amygdala. Now, things that increase output of epinephrine and norepinephrine, like drops in blood sugar, sensation of falling, psychological stress, stimulants, hypoxia, dehydration, they can all increase this activation to the amygdala. Or anything that decreases GABA activity, which inhibits it. GAD65 antibodies, GABA receptor defects, they can all cause increased activation. And then if the frontal cortex can't activate the basal ganglia and the basal ganglia is not working, you can have loss of inhibition of these pathways and get, in these cases, depression and anxiety put together. And then bipolar disorders, you basically have genetics and environment that causes dysfunction of these limbic networks. And anything that activates the neuroglia or causes fatigue of these limbic networks, the mitochondrial dysfunction, that activates bipolar disorder. So that's the basics of the neurology and neurochemistry and neuroendocrine-immunology of mood disorders. Hope it was helpful. Thank you.